What's that?
Taser?
A taser.
Recording.
It looks like a taser, that's what I said.
It's recording.
All right, so we're going to start. I'm thinking you know who I am, but in case you don't, my name is Amy Goldman, and I serve as the Director of Health and Counseling Services. So I have the privilege of working with a very wonderful team. You guys already got to meet Beth. How did that go? You guys like Beth?
Yeah.
She's fun. She's fun. Candy. We don't have candy. Okay. I'm going to ask, we have some people here to introduce themselves, and then they're actually going to leave after that. They're done for the day, so I wouldn't seem weird why they introduce themselves and then they walk out the door. But I want you to meet our team. There's one person who is not here, Toby Shope. I don't know if any of you guys know Toby. Okay, so he was actually with us last year. He was in Geneva's Master's in Counseling program. He did his internship and he graduated. And I'm very happy to say that we were able to hire him as a part-time counselor. He will be here this year for 20 hours a week. And then we have some wonderful new faces in the back. I'm going to ask them to stand up and introduce themselves. You guys can get a name with the face.
You want to go first this time?
Start on this one.
Hi, my name's AJ Hawk. I did my undergrad at Franciscan University, and I'm doing my master's in counseling there currently, and I'll be here all year doing my internship in the counseling center.
Yeah, I told them, they're part of our conference now.
And I'm Joseph. I'm from Memphis, Tennessee, and I'm in the master's program in Geneva as well, and I'll be here just for
I'm Julie. I'm a graduate student in the Master's of Counseling here in Geneva. And I did my undergraduate at Towson University. So I'll be here for 2 semesters.
My name is Brian Kelly. I'm originally from Bethel Park. I did my undergrad at Duquesne, currently going for my master's, and I'm going to be an intern here at the Counseling Center for both the fall and spring.
All right. So let's give them a round of applause. Okay. And I'm excited to be with you today because we've been in training all this week, and I told them, I said, if there's any department on campus that we work very closely with, it's residence life. Especially when it comes to mental health issues. I feel like in many ways you are the eyes and ears. You are going to notice things and see things with students before we are. And I think it's really important that we work well together. We have always worked well together. And Hannah and I want you to know that we are here to support you. And that's really what today is about, is we want to equip you with some skills. But we also want you to know that there's a time when you need to turn students over to us. And we will gladly do our best, to care for them. So we're going to focus on just a couple of things today. There's so many things we could talk about, but we're going to focus on mainly depression, anxiety, and suicide. So the information we talk about today may be difficult to hear. I want you to know that if you need to step out, whatever you need to do to take care of yourself, if you need to talk to someone later on, that's okay. I mean, some of these things might hit home. And I also want to say, too, that, we may talk about things that are personal. People may have personal stories that they want to share that would be really helpful, so that we keep what we talk about in here, confidential, and be respectful of that. What else? Okay, I have a couple protocol type things, and then we'll kind of get into the meat of the topic. So the first thing is, I was told that you guys already have the after hours emergency protocol in your manual for health and counseling services, which is great. So I just want to quickly just go over, and this is mainly if there would be an emergency, primarily when we're not open, but it also can be when we are open. So we are open every day. There's class, so Monday through Friday from 8 to 5. So if you have a mental health concern with one of your residents and you feel that they need immediate attention, What I'm going to ask that you do is that you get in contact with an RD. It could be your RD or the RD on duty, and they will get in contact with me. And if it is during our regular business hours, we will, if it's determined that they need to be seen right away, we will make sure that they're seen. One of the things that we have, and this isn't something that the whole campus knows about, but I can tell you guys about, is we do have a walk-in hour every day, Monday through Friday from 3 to 4. So we have a counselor who's kind of like the on-call counselor for that day. So we do have that free hour open, and if the student needs to be seen, we can get them in there. If there's an issue when we're closed, so in the evening after 5 o'clock or on the weekends, the protocol is the same. Contact your RD, the RD on duty. They will get in contact with me. So I am on call 24 hours a day. So we will determine together what steps need to happen in regards to if the student needs to be seen, if I need to come to campus, if I can talk to the student on the phone, and so on and so forth. So that's pretty much all that's really in here. And you guys have, and it also goes over like health services too. So any questions about that at all? You can read that in your manual. You guys good? Okay, all right. The other thing too is I want to hand out is how to schedule an appointment. So one of the things that we're doing this year is we're trying to get this information out to everyone, so everyone's really clear on how to make an appointment. So students can definitely, I do all the appointment scheduling, so students can call my office if they want, or email me. But honestly, the best way is to go online because I can be hard to get a hold of, and I don't want students to get frustrated. So this just kind of walks you through, you guys can just pass this around, how a student can schedule an appointment online. The information that I get from that is confidential, and my rule of thumb is that I get back to them within 1 business day, with an appointment. So we're going to have these posted all over the place, faculty and staff, so it's really clear. We want people to know how to access us. So that's that. And then the last thing I have is how many of you, if you're a returning RA, participated in our RA assessments? Okay. And then how many of you, this is your first year? Okay. So this is more for you. This is your first year. So just a little background. I forget how many years it was, but one of the RDs who was there shared with me something that she did at her undergraduate, which I thought was a great idea, is anyone who was a first-year RA came to the counseling center for like a mock assessment. And it served a couple different purposes. First of all, as an RA, most of the times you're going to be the person recommending a student to get counseling. Usually it's a friend that recommends them to get counseling, and they're more likely to follow through when it's a friend. So what if the student says, I've never been to counseling, I'm afraid to go? What happens in that first appointment? Those people are scary. I mean, I don't know what, or they had a bad counseling experience. So what we want you as an RA is to just get a general sense of what a first appointment looks like, give you a chance to meet some of our staff, and then we also talk with you a little bit about self-care as an RA, and talk through, like, have you thought about how you're going to take care of yourself? Have you thought about how you're going to set boundaries? And then it's also an opportunity that maybe you have thought about coming to counseling, or maybe you have some issues that you might want to work towards. We've had some RAs that have decided to come back for a couple sessions. I mean, you don't have to, but that's definitely something that's open to you, because this can be a stressful job at times. So what I'm going to ask that you do, this is only for first year RAs, if you've already done this, that's fine, is your name, and then if you have an idea of when you're free, so we're hoping to schedule these within the first 2 to 3 weeks of class. So if you know your class schedule, great. I did have a couple people write not sure. If you're not sure, that's okay. I'll reach out to you once classes start to go ahead and get that scheduled. So if you have questions about that, if you're like, I don't really know if I want to do this. If you have concerns, talk to me about it, talk to Hannah about it, talk to your RD about it. We really want you to do this. It's not a big deal. We are nice people, you know, just so you can experience it. And I honestly think you'll be in a better position to explain to a resident like what it's like. Because if no one's been to counseling before, that fear of the unknown is like really hard. So, you good? Any questions? Okay, so just sign up. You can just pass it along as we go. Okay. I think that's it. Oh, one last thing, and then we'll start. Has anyone here been through the 8-hour mental health first aid training that I did? What's your name?
Kristen.
Kristen? Okay. Just Kristen? Okay, great. I would encourage you, you do not have to do this. It is 8 hours. It's a big commitment, but I'm going to be offering this training once a semester for as long as I can. So for the fall, we're going to be doing it on November 2nd, which is a Saturday from 8 to 5. And you'll be hearing more information about this. And then we're also doing it again in April. If it's something that you can do, it is 8 hours. We're just giving you a tiny bit of information. It goes over a lot more mental health topics. I think it's a great thing to have as an RA, a great thing to have on your resume. It's free, so that's my little plug to encourage you guys to come if you'd like to come. Okay. All right, so let's start. So I know one of the things that Kelsey said to Hannah and I is she really wants for each one of these training segments for you to understand, like, why are we talking about this? So why are we spending time today talking about mental health when it comes to higher education? And here are some of my thoughts as to why. First, and this is all statistical research that is very relevant, 75% of mental health disorders develop before the age of 25. So 18 to 25 is that category of time where if someone's going to develop a mental health disorder, it's now. So it's important, to know about that. Early identification and treatment can lessen the impact of the mental illness. So what we want you to leave with today is we want you to know what are some signs and symptoms of depression and suicide and anxiety so that you can identify early on students that may be struggling. Because statistically, if someone can be identified early and they can get the appropriate help, there's a much better chance for them to recover. So we want you guys to help us with that. Because once again, you're going to be noticing things before Hannah and I ever would. And then unfortunately, only 18.5% of college students who could benefit from professional counseling services actually go to counseling. So there's a huge number of students that do not go. We continue to see more students as each year goes by. You can look at that in a couple of different ways. I like to be strength-based, and I like to say, good, there are more students out there that need help that are coming to get help, but there's a lot of them that aren't. Those are the students, to be honest with you, that I worry more about. I worry about the ones that we don't even know about, or the ones that we do know about but are reluctant to get help. So we need you guys to help us out. We need you guys to encourage students to do that. Real quick, just a couple of thoughts. Why do you think that is? What do you think are some of the barriers? Yes?
There's really a stigma about going and getting
Yep.
mental help.
I think that's getting better, but it's still there. Still there.
I had a friend that was afraid that they were going to be either punished or locked up for being crazy.
Okay? Punished or locked up, okay? Or kicked out of school.
Yeah.
And one thing I will say is what happens in the counseling services is completely separate from someone's academic record. It is confidential. It is not part of their record, and we make sure that students know that in their very first appointment. So that's something that you can say to students too. Yes?
A lot of them are probably coming from homes where their parents just straight deny mental health. I think it's like the previous generation just not doing a very good job at accepting it.
Yeah, right. Yeah, you don't need that. You can deal with it on your own. You know, so if their parents aren't supporting it, it makes it hard for them to want to, yeah.
Kind of similar to what was just said, but like they feel like the counseling center might overreact if they tell them about everything they think of.
Mhm.
They feel like the counselor might overreact and like report it or something like that, and they really just want to get it out, but they're
Yeah.
afraid that the person will overreact.
Yeah. If a student tells us that they violated the student handbook, we don't report that. I actually try to keep students out of the hospital, same for you. So we do everything we can to keep them out of the hospital, and sometimes obviously we have to do that. So those are some myths, I think, and barriers that maybe you guys can speak to. One more, yeah.
I think people downplay their own mental health. Like it's not that big a deal. Or I'm just stressed out from school without recognizing that there's a fear, and that help can actually
Right.
help.
Yeah, I've had students actually say to me in their first appointment, like, "Do you think I need to be here?" And I'm like, "What do you think?" Yeah, you're here. So, and I think too, like, we see students who have significant mental health issues, okay? Suicide, bipolar disorder. We see students who, I need to learn some ways to manage stress. So it's on a continuum, you know, so if they're even thinking about maybe making an appointment, just come in one time. You know, we'll figure that out together if they need to come back or how often. So there's no problem that's too small, you know, that we can't deal with. So, okay, good answers. I think you guys pretty much, it says on here insurance problems, limited finances. I just want to remind you that counseling is free. It is a free service here at Geneva, so if students think that that's not the case, it is. Cultural issues could be a barrier. Fear of the unknown, a lot of the things you guys already talked about. Okay. So we could talk about so much today, but we decided that we would focus on depression and anxiety for a couple reasons. First of all, it is the most common illnesses, the mental health disorders that we see with college students, nationwide, but also here in Geneva. So we figured it'd be great to talk about those two things. They are also very similar. They have similar signs and symptoms, and many times they can co-occur, which means a student can have some depression issues and also anxiety issues. So that's why we decided we would talk about that. Okay. So this is a short video. Honestly, I think it does a great job just giving you, my guess is most of you know something about depression. So I don't want to spend a whole lot of time on it. So I think this video does a great job just kind of summarizing what depression is. So we'll watch it. You don't have to listen to me talk too.
Press pause and play again. And then it works.
Refresh.
Huh.
That's not the video we're watching.
Yeah. That's what I guess.
That next one kind of interests me.
Yeah, we should talk.
Last 24 hours on death row. Have you ever seen what some of those death row prisoners like request for their final meal? Have you seen like Reddit feeds about that? I saw one that was like a single almond. Isn't that weird? Those people are creeps. Give me the shivers.
Depression is the leading cause of disability in the world. In the United States, close to 10% of adults struggle with depression. But because it's a mental illness, it can be a lot harder to understand than, say, high cholesterol. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time. Getting a bad grade, losing a job, having an argument, even a rainy day can bring on feelings of sadness. Sometimes there's no trigger at all. It just pops up out of the blue. Then circumstances change, and those sad feelings disappear. Clinical depression is different. It's a medical disorder, and it won't go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Depression can have a lot of different symptoms: a low mood, loss of interest in things you normally enjoy, changes in appetite, feeling worthless or excessively guilty, sleeping either too much or too little, poor concentration, restlessness or slowness, loss of energy, or recurrent thoughts of suicide. If you have at least 5 of those symptoms, according to psychiatric guidelines, you qualify for a diagnosis of depression. And it's not just behavioral symptoms. Depression has physical manifestations inside the brain. First of all, there are changes that could be seen with the naked eye and X-ray vision. These include smaller frontal lobes and hippocampal volumes. On a more micro scale, depression is associated with a few things: the abnormal transmission or depletion of certain neurotransmitters, especially serotonin, norepinephrine, and dopamine, blunted circadian rhythms, or specific changes in the REM and slow wave parts of your sleep cycle, and hormone abnormalities, such as high cortisol and deregulation of thyroid hormones. But neuroscientists still don't have a complete picture of what causes depression. It seems to have to do with a complex interaction between genes and environment, but we don't have a diagnostic tool that can accurately predict where or when it will show up. And because depression symptoms are intangible, it's hard to know who might look fine but is actually struggling. According to the National Institute of Mental Health, it takes the average person suffering with a mental illness over 10 years to ask for help. But there are very effective treatments. Medications and therapy complement each other to boost brain chemicals. In extreme cases, electroconvulsive therapy, which is like a controlled seizure in the patient's brain, is also very helpful. Other promising treatments, like transcranial magnetic stimulation, are being investigated too. So if you know someone struggling with depression, encourage them, gently, to seek out some of these options. You might even offer to help with specific tasks, like looking up therapists in the area or making a list of questions to ask a doctor. To someone with depression, these first steps can seem insurmountable. If they feel guilty or ashamed, point out that depression is a medical condition, just like asthma or diabetes. It's not a weakness or a personality trait, and they shouldn't expect themselves to just get over it, any more than they could will themselves to get over a broken arm. If you haven't experienced depression yourself, avoid comparing it to times you've felt down. Comparing what they're experiencing to normal temporary feelings of sadness can make them feel guilty for struggling. Even just talking about depression openly can help. For example, research shows that asking someone about suicidal thoughts actually reduces their suicide risk. Open conversations about mental illness help erode stigma and make it easier for people to ask for help. And the more patients seek treatment, the more scientists will learn about depression, and the better the treatments will get.
Okay. Cool. One of the things I forgot to say is I'm going to make sure you guys get this PowerPoint, so I don't want anyone to be like feverishly writing notes. So feel free to take notes, but I'll make sure you guys get a hold of this before. So I think that video did a great job just explaining, what depression is. We're not going to spend a whole lot of time on this because my guess is you're pretty familiar with depression, but these are some of the things that you want to be looking for with your residents that might indicate that there's some depression going on. To remember that depression can very much manifest in a physical way. You may not think depression when you see some of these physical symptoms, but that could be something that's going on, and you can see a list of possible physical symptoms. And then behavioral, once again, these are things that we can actually see. They're more tangible. So if someone is isolating, if they're missing classes, their academics take a drop, those are things that are more tangible, able to see. Once again, doesn't necessarily mean there's depression going on, But if they have several of these symptoms, I definitely think it's worth, a conversation. And you can simply say, like, I've been noticing that you haven't been in class this week, or I've been noticing that, your personal appearance has been neglected or whatever. Like, you want to be like concrete with what you're seeing, and then give them a chance to respond to you about what might be going on. And then finally, there's quite a few of psychological signs and symptoms. The ones that might be maybe not as familiar is anger or irritability, or I think those two ones. So a lot of times with adolescents or young adults, or sometimes more with men, depression might manifest more with anger or irritability. It can happen with women too. But that may not necessarily be, we might not be thinking depression when we see some of those things. So any questions about, I went over this fast. I'm going to make sure you guys get a list of this, but is that stuff you're familiar with, or anything not clear with the signs and symptoms? Are you guys good? Good? Okay. All right. Oh, there was a
Amy,
question.
I just
Oh,
have a
sorry.
question.
Yeah.
No, it's okay. What does it mean, tendency to believe others see one in a negative light? Maybe I'm not reading it right. What does that mean? Tendency? Yeah, I don't know. Maybe I'm not reading it
I
correct.
think it's like thinking that everyone else thinks badly of you.
That should probably be two separate ones. So, yeah, so they see themselves in a negative light, and they assume that everyone else sees themselves. So their thinking can be very distorted. Like, everything sort of is seen through like a negative lens. And it's hard to like help them to see that in a different way, especially if they're really deep in their depression. So yeah, I think it was worded weird.
Yeah, I was like, I can't tell if I'm just reading it wrong, but.
All right. Okay. So now here's some Hannah. Some Hannah. And some kitties. I'd like to say here's some
Hannah.
Some kitties. Hannah. Cats. What is that?
An adorable creature.
That's a dog.
Cuddles.
Thank you. So, who in here sees this and like instantly gets a physical reaction just by looking at it? You do? You do? So if this were to walk in front of the room, what would happen?
I'd be out of my chair so fast.
Okay. How would you be feeling?
Oh, excited. I would be chasing down the kitty. But not like chasing it down aggressively because they don't like that.
Okay. So who's allergic to cats? Okay. What does it feel like to be allergic to cats? What happens?
Oh, my eyes get itchy.
Your
neck
eyes
is
itchy. Your
You
neck
guys know what
starts
happiness
watering.
is? You've never been happy then. You can never hold a cat. I get the whole thing. Wow.
So you get itchy, your eyes get watery, maybe you get hives, maybe you get stuffy, maybe you sneeze, maybe some people. What's your name?
I'm Josh.
Josh, this is good for you to experience what other people experience, right?
No offense, I'm sorry, but that's awful.
No offense.
So, Becca, if you were to just tell yourself, like, stop getting eyes watery, what would happen?
They would still get watery.
Oh, really? Why?
Because I'm allergic to cats.
Because you're allergic to cats and you can't help it and you can't control it.
Right.
It is completely outside of your control. And if you could just say stop, you probably would.
Right.
But she can't say stop, Josh. Like, she can't. So how is this similar to, we were just talking about depression, and now we're going to talk a little bit more about anxiety. I'm not going to go very deep into anxiety because obviously we know that anxiety can manifest itself in many, many different ways, many different situations. I'm sure we've all experienced anxiety at one point or another in our lives. But the similar thing is that if someone's experiencing anxiety, they're experiencing all these different symptoms, you can't just tell them, stop feeling that way. Stop hyperventilating. Stop having your heart beat so quickly.
Knock it off.
Yeah, you're not experiencing happiness. No, we can't say those things. So when we start to experience anxiety, just like similar with depression, these are not things where we can tell somebody that their experiences are false and their experiences are not real and their experiences are a lie and they need to get over it. There's a lot of different things that come out of anxiety, different symptoms.
I'm sure you've all experienced some of these things at one point or another. Maybe your mind racing, jelly-like legs, restless legs, sweating, shivering, heart palpitations, unable to breathe, like different symptoms that people experience when they're experiencing anxiety. There is a difference between someone experiencing anxiety, just like someone experiencing depression, versus someone who's actually clinically diagnosed with an anxiety disorder. So what you guys may have experienced, if you're not diagnosed with an anxiety disorder, may be just a little season of this, maybe a taste of it, but some people experience this much deeper, much more often, continually, and these individuals typically will be great candidates to come to counseling, potentially medication, we're not sure. But we are not talking to you about how to treat everyone with anxiety. What is this one thing that happens to people with anxiety? Typically, not everyone with anxiety experiences this, but it is typical with people with anxiety will experience it in inopportune times. Yeah?
Panic attack.
A panic attack, thank you. Yes, a panic attack. So what's the difference though between a panic attack and an anxiety attack? Yeah, Chris?
Panic attack is a short time frame. So
Okay.
it's usually around, like the peak is around 10 minutes and it lasts for a short amount of time. An anxiety attack can be a longer period, but they're usually not as intense.
Mm-hmm. That could be true, yeah. That's like a good point. There is typically like the peak at 10 minutes. Yes.
One of them has to do with the trigger and the other one doesn't. So like one of them, you just have the feelings for no reason and there's not something that you can be like, okay, this is why I'm feeling that way. And the other one is like, oh, okay, yeah, like I have trauma or whatever and this triggers that trauma and then I have an attack.
Yeah. Do you know which one this is?
No, I can't remember. I think panic attack is the one that has the trigger. No, it's the other way around. Anxiety has the trigger and panic
so
doesn't.
anxiety attacks typically have a trigger, like you were saying exactly right. If you're deathly afraid of snakes and suddenly a snake appears, you may feel triggered, you back up, your heart starts beating really quickly, you start sweating. That's an anxiety response. The panic attack, we don't know what the triggers are. We don't know what's causing the person to experience all those symptoms. We don't know what's causing their chest to beat or their heart to beat so quickly in their chest. So this is something that can happen with people who struggle with anxiety, even people who have never struggled with anxiety in their life. Panic attacks can happen. So the interesting thing about you RAs here is that often panic attacks will happen to your resident when maybe they're by themselves, maybe they're just with a roommate, and you guys are typically the first people that kind of get called to come on and help the residents. And so I want to talk a little bit further about how we can help these individuals who are struggling with a panic attack. I have a panic attack protocol, which is also in your handbook thing, but I still want you to like hand it out if we have enough for everyone to have a copy. So pass those around. And this talks a bit more about panic attack. I advise you to spend some time reading that if you can, because it has some more information about what a panic attack looks like, what the symptoms can look like. And then it also goes into some exercises on how to help an individual who's struggling with this in the moment. So I'm going to go through 4 different exercises. I'm going to focus on a couple of these exercises right now. So when our heart is beating really, really quickly and we like can't catch our breath and things are shaking and we're just like out of control, what is one thing that we can control in those moments? Can I control my heartbeat?
Nope. Well, not usually.
That's weird. What were you going to say?
We can control our breath.
Breath. We can control our breathing. So that's the one thing that we can help the individual be able to regain their breath. So with them being able to try a breathing technique of, this paper talks about like 4 breaths in, or 4 seconds in breathing, hold it for 1 second, and then 4 seconds out breathing. Being able to sit with them, calm them down in a steady way, being able to make sure they're safe, make sure they're comfortable, but also not you getting all like, no, I'm hyperventilating because you're hyperventilating. No, like being able for you to remain calm and steady and control your breathing and then help them control their breathing in the same way. So breathing is one of the best things you can do, is helping them with their deep breathing. Another one is muscle relaxation, which you can read about on the paper. Another one is repeating a mantra, which you can read about as well. Another one, because I really want time for suicide. Another one is finding an object and focusing. This one I like. I use this often, finding an object and focusing on it and describing it. This is a grounding technique in a lot of ways. I do this also with like my 3-year-old niece for distraction purposes too. Because if someone is stuck so inside of themselves and all of this is going on, helping them see something that's beyond themselves, something maybe that's in the horizon, maybe even it's saying like, oh, do you see that blue water bottle? Yeah, I see that blue water bottle. Well, what kind of blue would you call that? What like material is it made of? What would you use it for? What would it look like if it was like a different color? What color would you want it to be? Being able to focus on this tangible thing and getting their mind to start thinking about something tangible and practical, because their mind is probably racing into all these places like, I'm gonna die, this is so bad, everything's horrible, which is completely irrational. So being able to go towards something just really rational and tangible. And it works with 3-year-olds sometimes too. So I'm gonna try a deep breathing technique with all of you right now. So this is a really well-known one called 4-7-8. And it is a breathing technique that people use to fall asleep at night a lot because it's like a really relaxing, calming breathing technique. And so you're not going to fall asleep because we're only going to do it like 3 times. But it's something to maybe even you're starting to feel a little anxious yourself. And this is something you want to be able to teach yourself to do before you take a test or maybe in your staff meetings or things like that. So we're just going to watch this little video if it works. So just do what they say. You breathe in 4, hold it for 7, and breathe out of your mouth for 8. Breathe in your nose. Easy? Everyone feel a little calm? It's pretty nice. There's a lot of other videos like that, obviously, on YouTube. So if you're sitting with someone, and I've done this before with friends of mine who get anxious around different situations, being able to like sit with them and even just do a video with them, do some breathing techniques with them right there in the moment is really helpful. So in terms of your roles as RAs in the protocol, first, when you see if someone's having a panic attack, we of course need to first assess if it is a panic attack, as in something mental, or if it's something that's medically related. Obviously, if they just fell down the steps and then they're having trouble breathing, there may be something else going on. If there's blood or something, like, just make sure you assess if there's something medical going on, and of course seek the medical attention that it needs. But if you know that nothing else is going on, they're okay, or if you know this is someone who's struggled with this before and they're able to say like, yeah, I'm having a panic attack, then sit with them in it. The second thing is remain calm. If you guys can remain calm, it'll keep the whole mood remaining a lot more calm before it heightens everything. So remain calm, make sure the student is safe in a safe setting. If they're standing and they're going to fall over, make sure they sit. Ask them. The third one is talk to them about what they need. Instead of telling them like the cat analogy, like instead of saying like, oh no, just don't get hives when you're around cats because you can't control that, talk to the individual and find out what would help them. So would it help you to go outside right now, to be away from all these people? Would it help you to go out into the hallway? Would it help you to just take a walk with me and sit with them, do those things with them, take the walk with them, whatever it is, so that you don't leave them alone. I think Kristen said that a panic attack typically lasts around 30 minutes or so. It could be a lot less. It could be 4 minutes. It could be 1 minute. But if you start seeing the symptoms getting more and more extreme, and you don't reach a point at about 10 minutes where they start lessening and getting better, then that's when we're going to need to start seeking some medical attention. Call your RD, call campus security, call 911 if it turns into something physical. So. But typically around 10 minutes, you'll start seeing them get a lot better. And they'll be able to breathe calmer, and then at that point, you're like, yes, I know this was a panic attack. We do recommend that you still talk to your RD about it. If it's something that happens frequently, I would talk to the client or the student about potentially seeking counseling, talking to us, because there could be another anxiety thing going on. So of course, reassure the student that they'll be okay, practice the deep breathing, the different things we talked about, and then stay with them until it passes. So any questions about the panic attack, anxiety stuff? I know that was like stupid fast.
Is there anything you should tell them specifically not to do?
Don't breathe into a paper bag.
Mm.
That's a myth. Yeah.
So don't breathe into a paper bag.
Right.
Like,
Don't
just-
deny what they're going through. Like don't, like we were saying with the cat, like don't say like, oh, you're not, like you're fine. It's not a big deal. Like,
Yeah, like I just know, like, I mean, I'm someone very close to me who, with the stress of his program, he was in schools teaching, and he had to like run up and down stairs to like help get it out and stuff. That was like what his strategy was. Like, I don't know if that's ever something that you should do or.
if that's what actually worked for him and he was able to tell you that that's what he wanted to do,
Yeah, it's always
then
good if they can tell
he
you
can
what works.
do it. Yeah.
Then
I'm
I
sure
would
everything was like, actually, maybe you should.
Yeah. Yeah, no, if they are in a clear enough mindset that they know what is going to help them, let them do what's going to help them, especially if, like you said, they've had experience with it before, so they know, like, this is what happens when I experience this, and this is what helps me. I would definitely say, if you guys see this happening very frequently with individuals and you don't see them seeking more help, try to encourage them to seek more help. Like, hey, you don't have to experience this all the time. Like, there are things that you can get help through this. There may be something else going on. You don't have to deal with this on your own all the time.
If
So
they really
encourage them to go to
affect their
counseling.
life. Yeah, if they really affect their life.
Yeah.
One way to start hope.
Mhm. So, any other questions about that? Okay, then let's go into suicide risk assessment. All right. So, why talk about suicide? Here is a very recent statistic, and let's see what you guys think. When it comes to college students, suicide is what leading cause of death? What do you think? Number one?
Yeah.
Number two. It's number two. So it's definitely up there. It's the second leading cause of death. So it's important to talk to you guys about this. And this is something that causes anxiety, understandably so. It causes anxiety for trained professionals too. So I want you guys to feel equipped to the best of your ability. And I also want you guys to know when you're out of your when you're out of your mode of training, and that's when we want you to involve your RD and us. And trust the fact that when you involve us, we will definitely be taking steps, and our priority is the student and keeping them safe. So we're going to talk a little bit about this. If you've had this training with me before, it's familiar information. The protocol really hasn't changed over the years. It's still the same, but it's definitely something to remind yourself about. So the first slide is suicide risk assessment. So when you think about, and this is different than like signs and symptoms of suicide, but when you think about certain categories of people, certain situations, what comes to mind? Like what might put someone at a higher risk to attempt suicide?
Gender.
So gender. What do you think about gender?
Well, women are more, or men are more likely to complete suicide, and women, because they're more likely to use more deadly means.
Yeah.
Are women more likely to attempt? I can't remember.
You're right.
Okay.
That's perfect. Yeah. So that is the difference between gender. So we want to be thinking about gender. What about some other categories? What about this one? Any ideas on that?
Is it younger and more likely to commit suicide than older people?
Well, it's actually both.
Oh, is it older? Is it
So
older?
adolescents, young adults, and the elderly.
Oh,
You know, so obviously we're working with young adults and the elderly. Just for time's sake, let's just throw out like one more. Let me think.
is it race?
It's not on there, but I'm sure. I don't actually know.
I don't want to say anything wrong, but I checked it. I don't think so. The only one, Native Americans, are pretty high.
Yes.
That's the only one that
And
stood
I
out.
would say Native Americans and Asian
But I don't have that on the list, but I mean, I do think there's some on there. So, so chronic physical illness, I mean, we may not see this with our students or not, but that's definitely a concern. That can affect someone emotionally, for sure. Just the fact that someone has a mental illness, now it doesn't mean that they are going to think about suicide, but if someone does have a depressive disorder or an anxiety disorder, you don't want to forget about if someone has chronic anxiety, that could increase their risk for suicide. If they're using alcohol or other substances, or if they have an alcohol or drug problem, because when they're under the influence, they're not thinking clearly, and they can tend to be more impulsive. If they have less social support, I think that one makes sense. If they've had a previous attempt, that puts them at risk to attempt again. And if they have a plan, and the more organized the plan is, the more at risk, the more concerned we are. And then here's some other ones, and you can see that if they've had a recent loss or a relationship breakup, sexual orientation, gender identity. The LGBTQ population is 4 times greater risk to attempt suicide. If their family is not supportive, they are a 9 times greater risk. So that is definitely a category that is at risk. Someone that just has a history of impulsivity or aggressiveness, any barriers or lack of access to care, lack of support system again, mounting financial burdens, unemployment, uncertainty. You may not see that so much with college age students, but definitely with the elderly. I think that's an issue. And then pressure to meet expectations. A couple other things I'll add, and this is from the American College Health Association, which is a great resource for statistics for college students. They mentioned academic stress as a concern, friends and family problems, romantic relationship problems. Reasons why college students don't attempt, it's good to focus on this too, is they don't want to disappoint their friends or their family. They want to finish school. One statistic with college students that is concerning is nearly 80% of college students who die by suicide never participate in counseling services. My colleagues at other colleges who have had a completed suicide on their campus, this statistic is true. So many of them, they did not know them. They were not an active participant in the counseling services at their college. So once again, it's those individuals that we don't know, we don't see, that are concerning. Statistics also say that with college students, they have seen a significant drop in depression and thoughts of suicide just after having 6 weeks of counseling. So counseling, statistically, there's research that shows it is effective for students that have depression and suicide. So that's why we want to do our best, to get them connected. Okay. So warning signs. My guess is you guys probably know this, so I'm just going to go ahead and put this up there. So there's quite a few. So you can look here on the screen. If you notice any of these things with your residents, obviously the more warning signs they have, the higher the concern. But even if there are a few warning signs, I would say this is when you need to have a conversation with them. You want to be sure. And you can simply say, hopefully you already have an established relationship with them, but you can say, I've noticed some things that you've posted on your Facebook page. They may not be directly saying I want to kill myself, but there's some things on there that I was concerned about. And I've noticed that you've just been withdrawn lately. And just specifically point out what you're noticing. And then we're going to talk about here in a minute how you actually ask the question or how you assess if someone is having thoughts of suicide. Any questions about any of those warning signs? Yes.
There's just a couple that were in the manual that aren't up there.
Yeah.
Like giving things away or making some kind of like will or funeral plans.
Like
and
possessions that are important to them.
And also if they have a sudden and dramatic improvement in depression.
Yeah.
Because a lot of times when people start getting help or start getting medication, there's a little gap there where they're not quite in a good place yet, but they're in a better place than they were, and so they're more likely to have the energy and means to complete suicide.
Yeah, and I think for that, what you're looking for is that sudden improvement. Yeah. And the other part of that too is they may have already decided that they're going to do it, and they know how and they know when, and that sudden improvement in their distorted thinking, they think this is good. This is good. I have a plan. So you want to be. That's a tricky one because you think you're improving, but you're not sure. Yeah.
Also, like giving things away or saying goodbye to people, like just being like, oh, you know, like unusual changes in how they interact with people, where they're like, oh yeah, like I really wanted to make sure I know that, like, you know that I love you, and like just wanted to say goodbye. I mean, it's not a situation that warrants
a lot of time
that.
your gut is telling you, like, if you have a relationship with this person, like, what's going on? Yeah, what's going on?
Because whenever, like, we think of giving things away, we usually think of, like, a possession or, like, a solid object that, I don't know, keepsake. But a personal story of mine is someone I knew back at home at a different school, and they ended up committing suicide before they did. They were, like, blowing all their money on, like, making their friends happy. So they, like, all went out, had a great time, and they're just paying for everything. So it doesn't have to be an object. It could be allowances too.
Yeah. Yeah, and I think we all have, a good gut instinct, I mean, I do think a lot of times this can be prevented, but if you're in doubt, if you're just wondering, ask. Definitely err on the side of caution, I think, when it comes to this. So thanks for sharing that stuff. Okay. All right. So what do you do next? So when you see some warning signs, okay, and what I want you to do next, and what I'm about to say is, you may be thinking, I'm not qualified to do this. Yes, you are. This is part of mental health first aid. Mental health first aid training is meant for every single person on the universe. It does not matter what level of training that you have. These are questions that we can ask. And these questions actually are asked better by someone who has a relationship with them. So you guys are going to have a relationship with your residents before Hannah and I are. So these are questions that we need for you to ask. If you feel like you cannot ask these questions, my hope is that you will, because you're in this position. But if you feel like for some reason you can't, then what I need you to do is I need you to find someone who can. So if you need to go get another RA on your floor who's comfortable doing it, or if you need to get your RD, you need to find someone, because we need to have the answers. So these questions are direct. So if you are not a direct person, or you are not you're more an indirect person, this might be hard for you, but this is what is being recommended from research that you ask. You ask either, you can ask one or the other, or you can ask both. Are you having thoughts of suicide? Are you thinking about killing yourself? Okay. Why not ask, are you thinking of hurting yourself? That sounds like a good question, right?
Because it's a different scenario, and some people may be self-harming and not planning to kill themselves, or some people might not be.
That's a different question. We want to be clear. We want to get a yes or a no. We want to be clear because that's going to dictate what we do next. Or if you say, you're not having thoughts of suicide, are you? Right. That person immediately is like, this person is uncomfortable. This person does not want to hear the answer. So you need to pay attention to your tone of voice and how you present it. And if you remember from the video, one of the myths is, if I ask these questions and they're not thinking about suicide, I just gave them an idea. That is a myth. If you talk to anyone who has had thoughts of suicide, that is a myth. what happens is someone who struggles with thoughts of suicide, there's a part of them that wants to live and a part of them wants to die. The part of them that wants to live, they're waiting for someone to ask them these questions. And when you ask them these questions and you do it in a calm, confident manner, in their mind, they're thinking, okay, this person is willing to talk to me about this, you know? And that's what you need to do. That's how you need to be. So, because these questions are hard, it's hard for me, I've been doing it a long time, we're going to just real quickly, what I want you to do, we've done this before, is I want you to find a partner. This should only take 30 seconds. I want you to ask those 2 questions. I don't want the other person to answer though. I'm not going to get into all that yet. And then I want you to switch. And then I want the other person to ask those 2 questions just to get yourself comfortable with saying it, the wording, how you present it. So go ahead. We'll take 30 seconds to do that. Find a partner. We're uneven. You might have to find 2 partners.
Which one of us asked first?
No, I wasn't nodding to that one. Okay, good. And then do you want to try the other one?
Well, I guess if you bring up like I have noticed.
All right. We'll bring it back. Hopefully, okay. All right. We bring it back. Just a couple people for time's sake. What was that like? What was that like? Awkward?
Shivers.
Yeah.
Right down my heart.
That's
Like
normal.
nervous, seeing like
Yeah. Yeah. That's normal. That's normal. You're gonna feel this way. That's why I wanted you to say it. And I would just encourage you to keep practicing it. I mean, this may sound weird, but practice it while you're driving, while you're in the shower. I don't know, but just keep practicing it. So, I don't know, I do weird things. So that you feel comfortable doing that, okay? But the important thing is that these questions, if you need to ask direct questions, because we want a clear yes or no answer. So what we're going to do next is we're going to assume that the person says yes. So now what? Okay, so they say yes. There are some other questions that I would encourage you asking. Okay? And once again, you can ask these questions. You do not need advanced training, okay? When it comes to suicide, I think I forgot to say this, very much suicidal thoughts are on a continuum, and what I mean by that is you either have someone that doesn't think about suicide, then you have someone that does, but that's all the farther they go. And then you have someone who not only thinks about it, but they're thinking about how they would do it. And then they start thinking about how they would do it, and they start to put more detail into it, okay? And then they start thinking about, well, do I have the means to follow through with my plan? And then they actually start to get the means to follow through with their plan. And then finally, you have someone who attempts. Yes?
Would you say there's almost like a gap between like thinking about like the details, but still thinking, but I'm not actually going to do it?
Intent. Yeah, you're right. I forgot to say about intent. So, and this is what these questions ask. So the first one is, have you decided how you're going to kill yourself? So that kind of gets to, are they thinking of a plan?
Yeah.
Okay. The next one is, have you decided when you would do it? So that's more intent. So you may have someone who says to you, yeah, I have an idea of how I would do it. I would walk in front of a car. And then the very next breath they say, but I would never do that. I can't do that. So they have a plan, but they don't necessarily have intent. Yes?
Do you think it might start sounding almost like an interrogation? Like if you're talking to a friend and you keep pounding them with questions?
Well,
do you feel like you lose
yeah.
the connection, or it's better to do that?
So for time's sake, I'm just giving you like the nuts and bolts, but this needs to be conversational. Yeah, you want this to seem natural and conversational. I mean, if we had time today, and maybe this is something you guys can do with your RDs, or you can invite us back, you know, like a role play would be like a really good thing to do. Huh? Behind closed doors, yes. Yeah, I'm assuming there's a suicide depression thing. So yeah, you want it to be more conversational. I'm just kind of giving you those key questions for today. Okay, and then the last one is, have you collected the things that you need to carry out your plan? And don't worry if you don't get these things. Those first two questions are the most important ones, okay? Don't worry if you don't get these ones perfectly, but you can, if they say yes, you can ask additional questions. And what we're looking for is, do they have a plan? How detailed is the plan? Do they have the intention to follow through on that plan? Do they have the means? You know, so those type of questions, that's helpful information to get. So what I will say at this point is, if they say yes to one of these questions that we already talked about, okay, it's fine to ask these additional questions. Whoops. I want you to get the RD, okay? I want you to get the RD on duty. If it's the RD of your building and you know they're down the hall, I want you to get the RD. And the RD has been told that they're going to get in touch with me, because I am on call 24 hours a day. Because at this point, if someone has said yes to suicidal thoughts, we need to make sure that they are safe, and we need to make sure what needs to happen next. That isn't something we're expecting you guys to figure out as an RA. That is something that the RD, with my consultation, will figure that out. What I need for you guys to do at that point is trust the fact that we're going to make the best decision that we can, and to know that that student's safety and the impact on you and everyone else, in their room and in their floor, that we're going to be thinking about those things. What happens next can be a whole bunch of different things, a whole bunch of different possibilities. I mean, we may say the person has to go to the hospital right away, and that would be Heritage Valley in Beaver, to be assessed, if they meet criteria for admission. Or we may decide, if it's during the day, they need to come down to the counseling center and meet with someone right away. Or we may decide, I think they're going to be okay for the night, they're going to come down and see someone in the counseling center first thing in the morning. There's so many different situations, but to know that we don't want you to have to be the one to decide that. We want you to consult with your RD. Your RD might need to come. And one of the things, we talked about this in our last talk, is one of the things that you can say to them is, they may not like the fact that you're going to call the RD, but to say to them, this is what I need to do. And I need to do this because they have more training and experience, and I care about you, and I want to make sure I get the best help that I can right now. So I'm going to call the RD right now. I would put them on speakerphone. You can say to the student, you can hear what we're talking about, and more than likely they're going to want to come over and talk with you. Okay? They may be mad. They may be upset. I know that's hard to have to deal with, especially if it's someone that you have a relationship with. And I don't mean this to sound rude or whatever, but at the end of the day, what really matters is that they're alive and that they're safe. So I'm fine if someone's mad at me. I mean, I'm not fine, but if I have to do certain things that will make them upset, that's okay, because I want to make sure that they're safe and that they're alive. And the hope is that they're going to understand that. They may not understand that in the moment. The hope is that they're going to come around. Most students come around because they're not thinking, they're not in their right minds right there. Most students will come around and they'll actually thank you. They'll understand why you did what you needed to do. Okay, I think one more slide, and then we definitely, if you have questions, this is just a couple other things to think about. Well, there's actually 2 more slides I lied, so let's see. Just some general things to think about. Let the person know that you're concerned and that you're willing to help. As I said earlier, you're starting the conversation off by saying, here's some things that I've been noticing. And then that kind of leads you into asking the suicide assessment questions. Ask the questions without dread. without any type of negative judgment. Appear confident, even though you may not be. This is where you have to pull out your acting skills, right? And appear confident. And some other questions that might be good to ask. You don't have to ask these, but is the person under the influence of alcohol or drugs right now? If the answer to that question is yes, then I would have some concerns about possible safety for them and safety for you. So this is where you might be making a call to security. If they've actually attempted, then we're talking about a call to 911 because we're now talking about a medical situation. And if they made an attempt in the past, you could ask that if you wanted. Once again, but the reason for asking that is that just lets you know that there's a higher risk they might do that now. But if you don't ask that question, that's okay too. Okay. I want to give you a phone number. That's a good number to have. And feel free to post this on your floor if you want. Real quick story. This is the National Suicide Prevention Hotline. The reason why I give this number out, and I like this, is because we had a real story here at Geneva where a student we didn't know called this number that I'm about to give you. And what happens when you call this number is they immediately connect you with the hotline in your county. So this person immediately got connected to the Beaver County crisis line. The crisis worker determined this person is at risk. I am concerned. So they're trained to contact law enforcement. Law enforcement contacted us. We were able to track the person's phone and find out what building they were in, and we were able to locate the person. So I say all that because students know about this hotline. They call this hotline. Obviously I would much prefer that they talk to you about it and talk to us about it, but maybe they feel more comfortable calling, a hotline. This is one that I feel really good about just because of how it works. So it's the National Suicide Prevention Hotline, and the number is 1-800-273, it's the word talk, or 8255. And I'll say that again, 1-800-273-8255. So that's a good number to have. That number's on our website. Feel comfortable with that one. Some other things to do to help them stay safe is to talk with them about past supports, involve them in decision making. Obviously, if a weapon is involved or the person is under the influence of alcohol or drugs, if you feel unsafe, if you feel they're unsafe, you would want to call law enforcement and security. We don't want you to put yourself in any position where you might be unsafe. Don't leave them alone unless it's unsafe for you to be there. We talked about that in the last. But if it's safe for you to be there, you want to stay there with them until, like I said, you're going to be contacting the RD. Most likely the RD is going to come and talk with you. Don't use guilt or threats. Tell them they're going to go to hell or they're going to ruin other people's lives. That's not going to be helpful. And don't agree to keep their plan a secret. They may ask you to do that. They may not want you to involve anyone else. You've probably heard this already this week. There are times when we have to involve others. What they do need to know is I can't keep this a secret and I can't keep this confidential, but it will be limited to only a few people. Only the people that need to know will know. This will not be blasted across campus or anything like that. You can't guarantee confidentiality, but you can guarantee, privacy and respect for the situation. Okay. We're going to have time for questions, I think. 2 minutes. But this is our building, in case you don't know where we are. This is McKee Hall. Right here is health services, and Hannah's office is here, and we also have another counseling office. So you'll enter the front of the building. If you enter the back of the building, is where my office is, and we actually have 2 offices over on that side of the building too. So when we schedule students for appointments, I try to be clear and I tell them, enter the front of the building, enter the back of the building. If they end up in the wrong place, that's okay. But it's a little tricky because we don't have like one main entrance, but, okay. Questions? I feel like I just read a lot of information. Any questions?
Comments.
Comments.
I know this came up, I don't remember in which conversation this week, but if you have a student who's talking to you and you say, hey, like I think it'd be a great idea for you to go to the counseling center, you know where it is, they say no, you kind of explain it. It's also a good practice if you ask them, hey, do you want me to walk you there tomorrow during such and such time? And that way, this isn't confusing for them, this isn't another barrier for them. You can walk with them if they're comfortable with that and show them where it is.
And you can actually be with them in the assessment too. We're okay with that too. There will be a point, we've had students that bring the RAs, they're going to keep bringing their RAs, which we'll allow that to an extent, but there will be a point where we'll ask the student to come on their own. But definitely that first assessment, it might help them if you come with them. We're okay with that if you come with them to do that. So no questions. You guys are good. Oh, yes.
I just had a question about one of the statistics. So, one of the statistics was about the LGBTQ community being 4 times more likely just in general, and then 9 times more likely if their family is not supportive. Does that include if their family, like, is that only if their family is actively unsupportive, or does that include if they're like not out and their family doesn't know one way or the other?
I believe it's more when they're out and their family does not support that. Yeah, from the statistic. And like I said, that statistic's all over the place, but I know that came from some of the national suicide statistics. It's just a population, just like, you know, the age group, male, female, that's another population that they have solid statistics that say are at higher risk. You know, and I mention that because we have students, you know, here in Geneva that deal with that. So something to think about. Yeah.
And just so you guys all know, like you know us now, if you ever have any random questions that you think of, you can email us, you can set up a time to meet with us. We don't have to do like official appointments with you. It was just like, hey, I have this question about like this student lives in my hall and I just want to know like what should I do with this? If you talk to your, I mean you can talk to your RDs, they are filled with wealths of knowledge, but if it's something in particular, you're welcome to come to us and talk to us about any of that. And it's all confidential.
I'd add Toby into that too.
And Toby too,
you know,
yeah.
Probably the 3 of us primarily, just because, you know, we know policy more and things like that. Yeah, we want to work together and help you guys out because we need you, and I hope you know you need us too. But we need each other. Yes.
I feel like I know.